Welcome to the What About Rural Health podcast, a place where research, policy, and real life stories come together to ask the critical question: what about the communities too often left behind? I am Chinasa, a development and global health policy strategist. And for me, this work is personal. From the village health workers struggling with limited supplies to the mothers walking miles for care, their stories shape the policies we need. Join me as we uncover challenges, spotlight innovations, and amplify the voices of those at the heart of rural health systems. Because every community matters, and it is time the world listens. Hello and welcome. You are listening to the podcast that asks the question many forget. What about rural health? I am your host, Chinasa Imo, and together we are uncovering the stories, challenges, and innovations shaping healthcare in overlooked communities. We are still on the introductory series breaking down rural healthcare issues, advocacies, policies, and systems reform. In this episode, we'll be looking at cancer care and rural health, technology, access, and rural health equity. So, while cancer is a leading cause of death globally, the gap in access to timely, affordable, and quality care is very evident in rural and low-income resource setting. But what if technology could help close that gap? So in this episode, Dr. Ndoh and I will be looking at the use of technology, particularly AI-driven innovation, how they are shaping and reshaping what is possible around cancer diagnosis, treatment, and follow-up care. We'll be looking at the intersection of access, equity, and innovation, and then ask, how can we ensure that these breakthroughs in oncology actually reach the people who need this care the most? Thank you very much, Dr. Kingsley Ndoh, for joining me in the studio today. And for those who don't know, Kingsley Ndoh is a global health leader. He's a visionary entrepreneur and the founder of Hurone AI. Hurone is a company that is transforming care through AI-driven innovation. But let's come back to Kingsley. Kingsley is leading the next generation of oncology solution by using scalable technology to reduce patients' costs by half, cut oncologists' follow-up time by 50%, and help healthcare systems transition to value-based care, all while keeping equity and patients' dignity at the center. So you see why Kingsley is here. With his expertise in AI policy and clinical research, he has sat in different advisorial roles, and one of those is with the U.S. president in the former administration. So the U.S. president's cancer panel and built partnership with top cancer centers, including AWS and other global institutions. His company is doing groundbreaking work using federated learning and diverse data sets to deliver precision oncology while protecting patients' privacy. And his work is backed by a team. Like when I look at your team on your platforms, like these people must be gurus. So, and they are actually, because they are from Microsoft, MIT, Fred Hutch, and Kingsley is working through these people to build a very strong narrative that is helping to redefine what is possible in global cancer care. He holds an MD, that's medical degree, from the University of Jos, Nigeria, and a master's in public health from the University of Washington. And he also has certificate in healthcare leadership and entrepreneurship from MIT. Now I see the connection. Kingsley is an affiliate faculty at Fred Hutch Cancer Center and the University of Washington. So, Kingsley, it's a pleasure to have you here.
Thank you so much. Really a pleasure to be here.
Yeah, thank you. Thank you. So, why did you choose to leverage technology for cancer care?
Yeah, so I started back in 2017 when I was reading a book called Humans Need Not Apply by Jerry Kaplan. I was on a plane at this time, and Jerry Kaplan was talking about the different applications of AI in different industries. And one of the things he mentioned that struck me was that healthcare data is the most abundant in the world. And even though we have this data, we're not harnessing it enough as other industries do. And then there was a stonewall, or basically almost like a gatekeeper's sort of like mindset in healthcare systems to use AI technologies, for obvious reasons. Some of it is sensitivity to patients' data, would AI take over what doctors do? So people were not really wired at the time to sort of like look at artificial intelligence technologies as one that could be augmentative rather than replacing. As doctors and patients alike, they have gone to medical school, residency, fellowship. They have all this expertise, and they're like, "What the hell, will an AI come to do when I'm a distinguished professor and an expert in this field?" So at the time, you couldn't just mention it in any US hospital or even in Africa or anywhere else, and people would, accept it. However, there were lots of experiments and there were lots of work going on, especially in the case of imaging and computer vision. One of the prominent companies that was already kind of looking at clinical decision making in oncology was IBM Watson Oncology. Unfortunately, that didn't work out because again, it wasn't the right time. People were not really like open, but that really sparked just an interest in me because I could see the huge potential that it could have both in the US and around the world. And fast forward to 2022, late 2022, I decided to, found Hurone AI when I pinpointed the problems that I thought would be transformational in solving. And the two things we're really looking at and we've been working on at Huron and with the partners we've had is two prongs. So one is solving the patient navigation problem. There are so many patient navigation tools around, but we don't still have. It's a bit static agentic processes. We'll talk about AI agents hopefully in the course of this. Are not really incorporated, and there's just lack of data diversity and understanding the social determinants of health or the patient's social needs beyond their clinical needs in such platforms. And that's kind of what we're changing because there's limited amounts of the healthcare workforce in general, and patients need support throughout their cancer treatment journeys. And the second bucket that we're solving is the fact that, patient care or care that is delivered to patients are not usually optimal, especially if that care is coming from outside the academic cancer centers. And so you see, even here, in the US, we have 80% of Americans that will receive their cancer care from community oncology centers, which are non-academic cancer centers, versus 20% that will go to academic cancer centers. And what you see is that even though you have these two ecosystems, there's a disparity in outcomes. So patients who go to community oncology centers, and some studies have shown that they have up to a 20% higher mortality risk. That might be very simplistic to put, but in general, they're just poorer outcomes. Obviously, community oncology centers are not homogeneous. There are some that are really great. There are some that are, maybe a 10 oncology clinic center. There's a lag, and one of the things that's responsible for this is that there's a lag between when there's a major treatment update to when it's implemented in bedside. And there are usually like 1 to 2 updates every month in the guidelines. So essentially, there's a lag between when there's a major trial update from implementing that trial update to the bedside. It takes about 3 months in an academic cancer center compared to 3 to 6 years in a community oncology centers. It's not really fair to patients that we have new treatments out there. We have genomic markers that have targets, and unfortunately, they can't be reached. So, anyways, this is a long-winded way of sort of like explaining how I came into founding Hurone AI, and leveraging technologies to solve these two big buckets of problems in the healthcare system.
Thank you. Thank you very much for taking me through this journey. And I've never had this part of the story before. So I really do appreciate that. And when you were talking and you mentioned, and it hit me, yes, oftentimes we say people like us from the policy side will like there's lack of data, or there is lack of data integration. But here you are saying there is abundance of data. However, they are not harnessed appropriately. And it drew me to a question that I wanted to ask you earlier on, to be like, when you look at data, and I know you've been hitting me with all of this data, but when you look at data and what it represents, what does it tell us about rural, around cancer care, but within, rural and urban disparity?
Yeah, so I mean, one of the major things, so if you look at the United States, for example, about 50 million Americans live in rural areas, right? And even a large portion of Americans also live in suburban neighborhoods, right? So just a very few people like in the city, and they're able to go to some of the large centers like here in Chicago, like going to University of Chicago is, be the major academic center there, and other ones like Northwestern and the rest. But you have definitely a divide because most rural Americans would go to community cancer centers. And a lot of times, even when they are clinical trials, they are based in more like bigger academic centers. So you definitely see that divide because those that live in more urban areas are getting the best care because that's where the best doctors are. That is where, academic, even if they're going to community oncology centers in the city, the best doctors are still there compared to rural areas. And so it creates this disparity. The other thing that is also a problem is the access to internet and also kind of smartphone devices. People that live in rural areas tend to be older people, and obviously the biggest risk factor to cancer is age. The more we age, we just have more risk of getting cancer. So, if you have, technologies that would help in navigation and stuff, those older people might not be able to be technology savvy to really help sort of like navigate them. So that also creates that creates a divide, right? Because if you're building technology, you have to also think about like older people, how are they going to use it? Is it user friendly to them? Are there alternatives if they can't use it? So those are some of the things that could be considered with rural health. There are several in terms of internet connection, obviously is I don't know if you know this, but internet connection is now considered a social determinant of health. Those that have internet connection have more likelihood to have better health outcomes than those who do not have, right? And there was the access program that the last administration started. It was a $42 billion project to take connection to rural areas. But unfortunately, that program hasn't been quite successful as of yet. But the good news is that we have other alternatives that use satellites like Jupiter from Amazon and Starlink from SpaceX, so those are, those are technologies that are coming up that could help people to be more interconnected. But the two things I'll say, in rural health disparities, one, access to the best specialists for what access to clinical trials, access to technology can be a challenge.
Thank you for that response.
Yeah.
And while you were talking, and then I begin to wonder if these are all the problems and they're already known by you. And so, how is Hurone AI now using these technologies that you've mentioned to enable care in these underserved regions? I really need to understand in terms of how Hurone AI is helping bridge this gap.
Yes, so Huron first started in Africa before it came to the US. We first had our first pilots in Rwanda, and because we knew that rural patients didn't have smartphones, we knew that they were English issues. They couldn't understand English, they could speak in a language. We made our technology very contextually and culturally appropriate, right? So we besides the app, we had a USSD system. USSD is, in simple words, just text, so they could communicate with an AI through text. They could report things and get responses through text automatically. And so that already solved the connectivity issue, right?
Good.
And then they could pick their language, and those kinds of things. So patients could report their side effects, they could get help with their side effects, and just things just through text, right? And if you're looking at and that's why technology has to be contextually relevant, because you could bring like cutting edge app or humanoid whatever, and if people don't have access to it, then you're just serving only 20% or 30% of the population. In the case of Rwanda, only 30% of the population had access to smartphones. The entire population, now the subgroup of the patient population might even be worse, right? And so, and that's why it's very important to consider the context on which you're deploying the technology, because if you deploy technology just without understanding the context or building for the context, what you're going to do is you're going to increase the inequality that we already have between rural and urban dwellers. In the US, there are several things we're doing. Obviously, in the US, it's a very different context. Internet, most patients, I'd say 99% of patients have smartphones. So we are not using USSD because that's not contextually relevant in the US. However, one thing we see is that, older patients tend to live in rural areas. They might not be tech savvy. And so on our app, it's called Hurona. It essentially have caregiver login. So a lot of times older people would have maybe their kids or, someone be their caregiver. And so if they're going to access information from the app or access anything from the app, it helps. It essentially, they can log in with their caregiver ID to get into the app. And I can actually show you a demo, so you see how it works. Because sometimes it's better to show a demo, and I think your audience and you yourself, you kind of get a better feel of what we have. So I'm going to just go to my phone and get into the Hurone AI app and pretend to be a patient.
Okay.
So this is a test patient. Her name is Evelyn, and she has stage 3 inflammatory breast cancer. And Evelyn just came back from the hospital, and she was diagnosed, and she has been walked up, and now she's just confused and she wants to start her navigation. Okay, can you see my screen?
Yes, I can.
Okay, so you can see here we can choose the language. We have Portuguese, Espanol, English. We can choose who Hurona you want Hurona to be. And like I said, I'm pretending to be this patient, this test patient, Evelyn, who has inflammatory breast cancer. So let's test it out.
Hi, Evelyn. I'm Hurona, your oncology support companion. How are you doing today?
Hi, Hirona. I am not doing well. The conversation with the doctor was very overwhelming, and I really want to understand my diagnosis and my treatment plan.
I understand that receiving a diagnosis and treatment plan can feel overwhelming, especially when it's a lot to take in all at once. Based on your recent appointment, you have inflammatory breast cancer, stage 33B, which means the cancer is locally advanced but hasn't spread to distant parts of your body. Your tumor is triple positive, meaning it tests positive for estrogen, progesterone, and IHR2, which actually gives more targeted treatment options. Would you like me to explain your treatment plan step by step to help you feel more comfortable?
So you mean that the triple positive is a good thing?
Yes, that's correct. Having a triple positive tumor means your cancer cells have three key markers: estrogen, progesterone, and HER2 that doctors can target with specific therapies. This actually gives your medical team more tools to fight the cancer effectively. It often leads to better treatment options compared to tumors without these markers. Would you like me to explain how each of these treatments works?
Yeah, Hirona. So I wanted to explain the first phase because that's what I'm fearful about. Like, because I know that it requires, was it neoadjuvant therapy that the doctor talked about? So I really want to understand it. Like, what kind of side effects am I going to be facing? What does it entail?
I'm glad you asked. Your first phase is neoadjuvant therapy, which means treatment given before surgery to shrink the tumor and make surgery more effective. Your doctors outlined a regimen called TCHP, which includes 4 medicines: docetaxel and carboplatin, which are chemotherapies that stop cancer cells from growing and damage their DNA, and trastuzumab and pertuzumab, which are targeted therapies that specifically attack the HER2 protein on your cancer cells. Common side effects you might experience include fatigue, nausea, hair loss, and numbness or tingling in your hands or feet. Your heart function will be monitored regularly because trastuzumab can affect it. Blood counts will also be checked weekly to watch for infection risk.
Oh my goodness, Hirona, sorry for interrupting. My heart is going to be affected. Now I'm scared.
I understand that hearing about potential heart effects can be scary, and that's completely normal. Your medical team will closely monitor your heart through regular tests to catch any changes early so they can manage it promptly. Many patients go through this treatment without serious heart problems, and the monitoring helps keep you safe. Would you like me to explain more about how the heart monitoring works or ways to support your heart health during treatment?
Yeah, I'd like to know about both because that concerns me a little bit. But I'm glad you said that very few patients would have any heart issues.
Absolutely. I'm here to help. Your heart will be monitored with tests called echo or MUGA scans, which are non-invasive imaging tests that check how well your heart is pumping. These are usually done before starting treatment and periodically during therapy to make sure your heart stays healthy. To support your heart, it's important to report any new symptoms like shortness of breath, swelling, or unusual fatigue to your care team right away. Maintaining a balanced diet, gentle exercise as advised, and avoiding smoking can also help. Does this help ease your concerns, or would you like me to explain anything differently?
Well, that eases my concerns. And Hirona, you know I don't smoke, and you have that in my record, so I don't know why you brought that up, but thank you. I really appreciate it. I think I would come back to you later. I have a meeting to attend to, but thank you so much for helping me.
I'm glad I could help ease your concerns, Evelyn. Please feel free to reach out anytime you want to talk or have questions. Take care and good luck with your meeting.
Yeah, thank you. So that's a little bit of a humanoid. And we have agents, AI agents that can help patients book their cab rides, can do all that stuff for them, can match their insurance. We just, everything automated, remind them of their appointments. It has memory, can ask how things are going from the last discussion. So it's a great way to navigate patients through treatment.
Wow. Thank you very much. This is fascinating to to see and to see it play out and how the AI tool is helping. Like when you were asking the question, the answer, I'm like, if half of the people sometimes have a medical care team, and this is me even relating to the human, healthcare delivery factor, like have a healthcare medical team who comes this detail to describing and understanding from the patient perspective how much anxiety patients walk out with healthcare information that is given to them by their care provider. That will solve a whole lot of, emotional and mental health issues that people navigate as well when they are going through healthcare challenge like cancer. So thank you very much for demonstrating that to our listeners to see how this AI tool works. All right, so we're going to take a short break, and when we come back, Kingsley and I will still continue to have this conversation. Welcome back. So, as we progress in this discussion, I want to ask you a question, Kingsley. So, having done this in Rwanda, where you piloted it, and now expanding here in the US, what can rural healthcare system generally learn from your work and the approach that you have adapted AI to use for cancer care accessibility?
Yeah, so here in the US, for every one patient that an academic cancer center sees, there are 3 patients more that a rural cancer center will see. So whether it's rural or academic, doctors have very limited time. Rural cancer centers in the US, they don't have the resources for human navigators. And even when you have human navigators, they also have very limited time, right? But now you have Hurone that really understands you, understands, we have wearable data, so you can monitor your sleep. It monitors everything about you. And you're having these very intelligible discussions with vetted information because we're trained, on oncology data, and we're having exclusive licensing agreements with major cancer centers, data licensing agreements with major cancer centers here in the US that I can't mention at this time. But this is something that personalizes the cancer patient's journey. It helps you with your insurance, figuring out if you want to do a second opinion. It helps you with the information to discuss with the doctor. It helps you with booking your bus ride. It helps you with booking an Uber with autonomous agents. So, this is the future. This is the present for rural health and healthcare in general, because the doctors want to perform at the top of their license. Once the doctor is seeing a patient and Hurone has already told the doctor, this is all the things that the patient have experienced from the last time you saw this patient till now, instead of the doctor to say, okay, hello, what happened? The doctor would be like, oh, Evelyn, you had some vomiting 2 weeks ago, and I saw you did this. How is it? How are you feeling now? Evelyn will be much more happy and satisfied because they know that their doctor has an in to what has been happening, than just telling Evelyn when you only have 15 minutes and you're telling Evelyn, okay, tell me what has happened. And sometimes Evelyn can't even remember everything because she's already overwhelmed, right? And so you want doctors to perform at the top of their license. As soon as they see a patient, they already know the key things. They've seen the trends based on what Hurone has presented to them in front of them. And they can basically make that 15 minutes the most productive 15 minutes of any doctor-patient visit. And on the other hand, Evelyn will go home knowing that even if I don't have speed dial to call a doctor or to call a nurse, I have Hurone by my side that is monitoring my sleep, is monitoring my activity, is monitoring, my temperature. It's asking me questions that would measure, whether I'm depressed or whether I'm happy. And all that, would help me navigate my treatment. I don't need to go to Google where I don't know what information I'm reading or to how to vet it because I'm not an expert.
That's true.
I don't need to go to ChatGPT, which could be helpful as well, but ChatGPT doesn't really understand some of the context, and I might not even prompt engineer ChatGPT well. But this is Hurona that understands me, that understands my medical history, that understands my activity levels from my wearables, and can really provide me that kind of navigation that I need to be better. And studies have shown that people that have adequate navigation just have better cancer treatment outcomes.
And this is it's even fascinating when you discuss this and you're not, I mean, I know you might get there, but looking at the communication breach between the doctor and the patient, because they are also on this other side of the app, and then the patient is on this side, and what that means is that both are looking through together, understanding how this care is happening.
Yes, absolutely.
Wow. Thank you. When you mention wearable wears, and I looked at myself, I'm like, I'm wearing an Apple Watch. And I know many people, especially here in the US, wear Apple products. Is that integrated or is it a different product? I'm just asking.
No, it's not. You don't need to. Yeah, that's a good question. Sorry, I maybe I cut in early, but it's not a different product. If you think about it, there's all sorts of wearables. There's a Fitbit, there is Samsung, there is Sony, there is Apple. There's I don't know if you've seen the Aura rings, where there's a ring you wear and it
Yes.
takes all this. So all we just need, all we just integrate is an API that harnesses all that data, and we're able to make sense of it. Obviously, all this is with the patient's consent, and the data is just used for the well-being of the patient.
Thank you. Thank you for responding to that, because at some point I'm like, does it mean someone who needs to have this tool needs to go and buy another wearable device, even when they have? So it's good that you mentioned that all we need to do is have an integrative API that gets into our already existing devices that we would have. And that brings me to my next question: the role of partnership in this. Partnership policy and local empowerment in scaling health tech solutions.
Yeah, so I'll just mention something very quick with wearables. So wearables are not a prerequisite to the app working. It's just that wearables, if someone already have a wearable device and they integrate it, it really enriches the experience. But it doesn't mean that because it gives us a lot of objective data as well. Like for example, if a patient is all of a sudden, we're noticing in the trend that or Hurona notices that the patient is not sleeping well, or they're having less REM sleep, or they're having less steps activity level, and then Hurona asks Evelyn, how are you feeling? And Evelyn say, I feel sad. And then Hurona can put 2 and 2 together. We can crunch all that data and say, oh, this is kind of getting to clinical depression. We need to escalate this, or if a patient is having like fever, and we know that fever is one telltale sign of what we call febrile neutropenia, which could be fatal to patients on chemotherapy, and so it can escalate it and say 911 should be called immediately. So those are it makes the experience much better, but it's not a prerequisite to use Hurona. That being said, your question was around partnerships. Partnerships are really very important to us. We're working with some of the major academic cancer centers in the U.S., like Johns Hopkins, Mayo Clinic, UCSF, where we're working with not just the clinical expertise that we're infusing into the platform, but also piloting it and clinically validating our platform. And academia is the best place to do it, and they're the best place to push this technology to the community. So we're really excited about our partners and what we're doing together. The other important partner is nonprofit. So we work with a nonprofit a group here in Seattle is called Sierra Sisters, which is a breast cancer organization. We work with another organization, which is another nonprofit in Boston. It's called Cancer Hackers Lab. These organizations bring the patient's voice for us. We need to understand the patients. We need to understand their pain points, and we need to make sure that we're engineering our product in the most empathetic way possible that actually solves problems for patients. And so it's really important to partner with the right groups and even data partnerships. We do have data partnerships for our platform to be intelligent. We need to partner with data institutions that license their data to us. We have also international partnerships. We are working with Aga Khan University Hospital, which gives us a little different types of data in Kenya. And global collaborations too are really important, like, the one we have in Kenya, because there are certain cancers that are not prevalent in the US, but they are more prevalent in places like Africa and other parts of the world. And there's so much you can learn to actually even help Americans and help people from a global health perspective. An example of that is a cancer called Burkitt's lymphoma. Burkitt's lymphoma is a childhood cancer that, for some reason, 90% of cases around the world occur 10 degrees north and south of the equator. And so you hardly see that in the US, but it still happens in the US. And the only way you can even study those is to study it where it's prevalent. So I'm just giving that an example to show that, data diversity, working with other populations can really come back to improve our system in working here in the US as well.
Thank you so much for taking time to explain this. And as we wrap up this episode, I have one question to ask you, Kingsley. Where do you see the biggest opportunities for digital health to transform rural care more broadly?
Well, I think the biggest opportunity is really for healthcare systems, governments to start thinking around investments, the ROIs, the business models, because if and it's already happening in the US. It's a very focused AI country, as you know, is a major innovator in AI. So it's easy here, and it's not easy, but it's easy relatively. However, if you go abroad, it's so difficult to implement some of these things because there's really no business model yet that they see. They love the technology sometimes, but it's because some parts of the world are very used to aid, and they don't really think about how can they make these business models. And unfortunately, it could leave certain countries behind. So the key opportunity, honestly, is investments and creating business models for workflows, because the future and actually the present of healthcare beyond cancer is the perfect symbiosis of humans, AI, and big data.
Thank you so much, Dr. Ndoh. It is just amazing, when you talk about the role of government in all of this thing, because I hear all of your points, and then when it comes to government, I think that they are very important in terms of how they spearhead policies and open up enabling environment for innovators like you, to come in and do what you know how to do best. So especially in areas like you'd mentioned, the global south, I made the argument that healthcare should be accessible to everyone, irrespective of A, B, C, D, Z, including money. And the person asked me, healthcare is costly. Where do you think people would get money, or where do you think government would get money to afford those care? And we get on talking to the point where we begin to see why different programs may end up not being sustained, because at some point there should be a sustainable model. And that is why I was happy when you mentioned government investment, but also the mixture of market-driven models that could help in ways that enables these systems to continue to sustain themselves. So thank you very much for throwing that in. But most importantly, what I take out from this conversation today, at least if I'm walking out of this episode, I am hearing that there is a need to improve healthcare providers and patients relational conversation in healthcare giving. And sometimes there are different factors that pose as challenges to making that happen, especially in removed and marginal areas where those factors could be, internet, transportation, and even unavailability of specialists. And technology is helping bridge that gap. But also, you are working with experts to figure out how to build patient-centered care that privileges equity and respect for those who come to access care, even with those conditions. So thank you very much, Dr. Ndoh. Is there any last word that you want to leave my audience with?
Well, I think it has been a great discussion. Thank you again for inviting me. I would say my last words are, in building, we need to be patient-centered, as you said. We want to ensure that the right regulations are in place, regulations that protect the patient, but not to stifle innovation. And we need to think around the right business models to scale technology like this.
Thank you. Thank you, Dr. Ndoh, for coming to us
Thank you.
today.
Yeah.
Thank you to our viewers for listening to What About Rural Health. If this episode moved you, taught you anything, or made you think, please share it, subscribe to our channels, and engage with our upcoming episodes. And do not forget to leave us a review. You want to get more involved, head to our website. You see ways on how you can get involved with us. Also follow us in all of our social media platforms is at whataboutruralhealth.com and be part of the conversation. Because healthcare is not just about systems, it's about the people that systems were built for. And because we do not want people in marginal areas to be left behind, we will continue to ask the question, what about rural health? And hope that we can build that narratives together. Until next time, I'm still your host, Chinasa Imo. Thank you and have a lovely day. Bye.